Hi, everyone. Thanks for joining us today. I'm Joanna Sinwell. I am secretary of the board on the board at NAMI, Johnson County, Iowa. And we've got two wonderful people with us today from the Employee Benefits Security Administration. They're located in Kansas City, and they're going to uncomplicate mental health parity for us today. And I'm going to tell you a little bit about our folks. And I'm going to have some help with your last name, Sarah.
Oh, that's perfectly fine.
Sarah
Guerricagoitia.
Guerricagoitia. Okay.
There
You
we go.
started with the Social Security Administration in 2018 as a benefits authorizer after graduating from the University of Missouri, Kansas City, with a degree in interpersonal communications. You've transitioned to your current position as a benefits advisor in the Kansas City Regional Office, Outreach Education, which is what she's doing today, and Assistance Unit in 2019, and has been protecting the health and retirement benefits of the American people. We're sure glad someone's looking out after us. And we also have Mary Lynn with us today, and it is Mary Lynn, or is it Mary?
I go by both, but let's go for Mary Lynn since we have another Mary today.
All right. You have worked informally to resolve numerous inquiries regarding pension and welfare benefit plans. You work with participants and beneficiaries, plan administrators, and service providers to respond to complaints and requests for technical assistance information and to provide education and assistance. You received your Bachelor of Arts degree in History from Washburn University of Topeka, Kansas in 2014. And for several years, Mary has worked to assist the public with retirement and benefit questions and issues. You've worked at the U.S. Department of Veterans Affairs, the U.S. Railroad Retirement Board, and you joined the Employee Benefits Security Administration 4 years ago. So welcome to you. We're recording today's presentation, so please, we have a small group today, but please feel free to share this with your friends and anyone seeking assistance with this very complicated topic. Thanks.
All right. Okay. So, as Joanna said, my name is Sarah, and today we are going to be talking about compliance assistance on mental health parity. Mary Lynn and I do ask that if you could ask questions towards the end, that would be better, just because everything can be a little technically complicated, and we might throw personal examples in there as well that aren't included on the slides. Okay, so the mental health parity, it was actually a response to the inconsistency in insurance coverage between health insurance coverage for mental health and substance use disorder benefits and medical and surgical benefits. The argument was that they should be on par. So that's now why we have this law, the mental health parity law. And there were two major mental health parity laws at the federal level, the Mental Health Parity Act of 1996 and the Mental Health Parity and Addiction Equity Act of 2008. And what the 2008 version did, it essentially added aggregate lifetime limits and annual dollar limits for substance use disorder benefits. All right, so mental health parity law protections have recently been expanded, and the Department of Labor and other agencies are currently working on rules and guidance to implement these changes. So this presentation is only going to cover the release guidance that is approved and that we are able to share. The Mental Health Parity Addiction Equity Act requires group health plans to provide mental health and substance use disorder benefits at parity or comparable to medical and surgical benefits. So it's just as it sounds. We want them offered on par, almost equally, almost the same treatment. Who is subject to the Mental Health Parity Act? So employer-sponsored health plans and health insurance issuers offering health insurance coverage for medical surgical benefits and mental health substance use disorder benefits, private employer plans, 51 or more employers, and most smaller employer plans as well. And then health insurance coverage sold to individuals through the marketplace. Okay, so now this is a question that I do think I have gotten a lot. I don't know about you, Mary Lynn, but this is a question definitely that comes up. It's, are they required to be offered? Well, federal mental health parity does not require group health plan or issuers to provide mental health substance use disorder benefits, but does require that when such benefits are offered, they are in parity. So if they're not offered, no, you don't need to comply with it. But if they are going to be offered, yes, there needs to be parity that is in your plan document and everything.
And just as a side note, retiree only plans are not included in the parity requirements too, if that ever comes to their attention, retiree only plans.
Thank you. That's really important. Thank you. Okay, so what protections does mental health parity provide? So there are going to be financial protections and treatment limitations. So all financial restrictions and treatment limitations applicable to the mental health and substance use disorder benefits must be comparable to the requirements or limitations applied to medical and surgical benefits. So when we talk about financial requirements, you can think of copays or deductibles. When we talk about treatment limitations, you can think of how many visits you have to go see your chiropractor or your psychiatrist. So if someone was to say, as an example, if a copay was $70 for a psychiatrist, and then to see your primary care doctor, it was only $20, that would not be in parity. So that would be something violating the mental health parity. General mental health parity requirements. So prohibited are lifetime and annual dollar limits on mental health and substance use disorder benefits that are lower than those limits imposed on medical and surgical benefits. And then cumulative financial requirements or cumulative quantitative treatment limitations for mental health, substance use disorder benefits that accumulate separately for medical surgical benefits in the same classification. And what is required, and this goes more into denials of services sometimes, is that there must be a disclosure on criteria for medical necessity and reasons for the denial. They have to explain why it is being denied. And so there are going to be 6 classifications of benefits. There's going to be inpatient, in-network, inpatient, out of network, outpatient, in-network, outpatient, out of network, emergency care, and prescription drugs. And these classifications, they are important to note, just as a general rule. So if the plan provides mental health, substance use disorder benefits in any classification, in any one of those 6 classifications, mental health and substance use disorder benefits must be provided in every classification in which medical surgical benefits are provided. A plan may not impose a requirement or a limitation to mental health / substance use disorder benefits that is more restrictive than the predominant financial requirement or treatment limitation of that type that is applied to substantially all medical surgical benefits in the same classification. Okay, so we talked on this earlier. This is just a general example. So we have Josh, he's going to the doctor, he's employed by Group Health Plan X. So for his psychiatrist, outpatient, and network mental health, copay $75. For primary care, same classification, outpatient and network physical health, copays $20. This is not permissible. The financial requirements applicable to mental health and substance use disorder benefits are not comparable to the financial requirement applied to medical surgical benefits in the outpatient and network classification. As a general rule analysis, you are going to need to identify the classification, whether it's inpatient or outpatient and network, inpatient and network, the type of financial requirement or quantitative treatment limitation, the predominant level of copay applied to substantially all medical surgical benefits within the classification, and result, this is the most restrictive copay that can be applied to mental health substance use disorder after going through this whole general rule analysis. Okay, so there are special rules, multi-tiered prescription drug benefit plans. Those can be offered as long as multiple network tiers. Also, subclassifications for office visits, separate from other outpatient visits, are permissible as well. Okay, so now we can get to non-quantitative treatment limitations. And non-quantitative treatment limitations, also known as NQTLs, they can be a bit more difficult to identify, but they also require parity. So a plan may not impose an NQTL on mental health or substance use disorder benefits in any classification unless any processes, strategies, evidentiary standards, or other factors used in applying that NQTL are comparable to and applied no more stringently than other factors that are used in applying that NQTL to medical surgical benefits in the classification. So here are just some basic examples of non-quantitative treatment limitations that that we often come across, and this is not the full list. There are so many out there, and I'm convinced insurance companies are still coming up with new ones. An example, medical management standards that limit benefits based on medical necessity or medical appropriateness, or based on whether the treatment is experimental or investigative. Pre-authorization or concurrent review standards, standards for provider admission to participate in a network, including reimbursement rates. And more examples could be plan methods for determining the usual, customary, and reasonable charges, refusal to pay for higher cost therapies until it can be shown that a lower cost therapy is not effective. This is usually known as step therapy or fail first therapy. So sometimes patients will get denied. They'll call us and they'll say, well, my insurance carrier won't cover this benefit unless I try A, B, C, D, and E. That's a warning sign in some cases. And then restrictions based on geographical location, facility type, and provider specialty that limit the scope or duration of benefits for services. I can personally say I have noticed that the geographic location has been more of an issue lately. Mary Lynn, would you agree? Have you run into more cases like that?
Yes, and I actually attended the Missouri Rural Health conference, which obviously it's not Iowa, but it's Missouri. And a big issue that we're hearing from the providers and the clinicians and people in that world, especially with mental health, is that there's a lot of issues around network adequacy, but also related to the parity is linked to that as well. And so you're seeing a lot of these plans and these insurance companies putting up restrictions for people based on where they live, and that's a major problem. So it's definitely something to be on the lookout for. And as was mentioned at the beginning here by Joanna, she mentioned the rural areas, which I know obviously Iowa's predominantly, or you could say a lot of the population is rural. So this is something that's important to look for in these plans. And as Sarah mentioned, the problem with NQTLs is they can be a little bit harder to identify on the surface. It may take a little bit of digging, challenging the plan, asking questions, and looking into it a little bit more to see if there is parity with how the mental health and substance use disorder benefits are offered on par with the medical surgical.
Right. And as we know, insurance companies love to respond to us and give us answers. So no, they don't. Now the definition of a non-quantitative treatment limitation. So an NQTL is a limitation on the scope or duration of benefits for treatment, as in one of our examples, such as medical necessity determinations or fail first practices. Again, trying to do A, B, and C before the insurance company will pay for something. They are generally not going to be expressed numerically, and that's where it can get a bit harder, because I think in terms of trying to identify, when we try to identify problems numerically, it's easier to do. But a plan may not impose any NQTL that is a separate treatment limitation applicable only to the mental health and substance use disorder benefits. Compliance is required as written and in operation, and plans are allowed to consider clinically appropriate standards of care. But it's important to not focus on the same result because outcomes are not necessarily always going to be the same. I will note a plan cannot have an NQTL that is applicable only to mental health or substance use disorder benefits. Okay, so some warning signs. Blanket pre-authorization requirements. So pre-authorization required for all mental health or substance use disorder services. That is a big, I would say this is a big complaint that we get as well. Treatment facility pre-authorization. So if admitted to a mental health or substance abuse facility for non-emergency treatment without prior authorization, the insured will be responsible for 100% of the cost of services received. If that happens, that is a big warning sign. Contact us. And then prescription drug pre-authorization. This has been actually happening a lot too, where we're finding that pre-authorization is required every 3 months for pain medications, and not even just pain medications, but medications prescribed in connection with mental health and substance use disorder benefits. So it can sometimes be a battle getting the insurance company to reissue another pre-authorization for another 3 months. And then sometimes the process just starts all over again. Treatment attempt requirements. So for any inpatient mental health or substance use disorder service, the plan or issuer requires that an individual first complete a partial hospitalization treatment program. And then the likelihood of improvement, which I have noticed that this is popular, but these cases are, in my opinion, a little difficult to deal with because essentially the plan or issuer is going to require that the likelihood that an inpatient treatment will result in improvement, but it's hard to express how someone is going to improve when it's something that you can't necessarily put in measurements, if that makes sense. And then treatment plan submission on a regular basis. This is also true for treatment plans regarding like depression, eating disorders. Plan issuer requires that an individual specific treatment plan be updated and submitted in general every 6 months. So if you notice any of these warning signs, or even if the conditions feel a little bit more burdensome, I would strongly recommend contacting the Department of Labor and speaking to a benefits advisor. That way we can fully look into the issue for you and make sure that it's not an NQTL.
Yeah, I was just going to add to that real quick, that with the last point made here, treatment plan submission on a regular basis. So this would be like examples of plan provisions that limit residential treatment or may impose geographical limitations on where treatment may be provided, or could require certain licensure of facilities where these requirements are not also imposed on medical surgical benefits. So that's kind of a red flag.
Right.
So basically it's like if you're like, man, they just really seem to be making the plan or the
Like
insurance companies
hoop
making this
after
really
hoop.
difficult. Yeah. Why are they putting up all these barriers and why are they making us jump through all these additional hoops? Something doesn't seem right here. Follow your gut. That's probably a red flag that they're, the big question we have to, that will lead you to is, are they doing the same thing on the medical surgical side with the same, treatment that would be comparable on that side of things?
Mhm. Yes, most definitely. All right. Questions you might want to ask. Does the application of the NQTL include similar requirements for medical, surgical, and mental health and substance use disorder in writing and in operation? So again, are they more Do they require more effort? Do the mental health substance use disorder benefits require more work than medical or surgical benefits? And is the reasoning for applying the NQTL to mental health slash surgical substance use disorder benefits supported by evidence? And the evidence being used, is it being used in a comparable way? And is the process in applying the NQTL similar or comparable? I will say a lot of denials that we sometimes do come across when they say that it's not supported by evidence, but plans, you need to dig further, because plans aren't always going to provide you an adequate reason as to why something is not necessarily supported by evidence. So again, I would suggest contacting the Department of Labor for that. NQTL questions to ask: Are the differences arbitrary? Are the difference in the application of the NQTL to mental health substance use disorder benefits consistent with practice guidelines? Is it harder to pass the NQTL for mental health substance use disorder than it is for the medical surgical? If it's harder, yes, likely there's a problem. Are the consequences more severe for failing to meet the NQTL requirement as they apply to mental health and substance use disorder benefits? All right, and then Miss Mary Lynn is going to take over.
All right. Thanks, Sarah.
Yeah.
Yeah, we're about halfway through the presentation now. Hopefully you guys are still with us, still awake. Like Sarah mentioned at the beginning, we're happy to take some questions at the end. This is kind of a lot of information being thrown at you. It's kind of technical. And just to reiterate, our department, EBSA, we do have direct jurisdiction over employers as the plan administrators for these group sponsored or these group health plans. While we do deal with and practice enforcement over insurance carriers, it can depend on the situation, how we're going to approach an issue with compliance. It could be that we're working directly with the fiduciary or employer that's sponsoring the plan to fix issues, and or the insurance company. But just so you know, when you're running across these issues with your patients or those that you're helping and treating, if you feel that there is a problem, probably the best and first step is to have that patient maybe give us a call. And we probably want to ask them some questions to say, hey, have you had a conversation with your employer HR benefits department about your concerns or about these denials or adverse benefit determinations or your inability to get pre-authorization for treatment for you or your child? Because we want people to come to us if we can early on in the process rather than after the fact, because it can be, not that we can't step in and provide hopefully informal resolution or enforcement capabilities to the issue after the problem, but it's easier toward the beginning, if that makes sense. It can be like pulling teeth to get, for example, I have a case that I've had open for a while for a gentleman who sought substance use disorder treatment from a inpatient facility in end of 2021, early 2022. We're trying to clean up all of his claims. He had basically a $60,000 bill that he's been trying to hold off on paying because the insurance didn't properly pay the claims. It's a long story, but it's so much easier had we had the conversation with he and his wife prior to admittance or around, and I understand a lot of situations around mental health, they just happen. You don't plan for them, especially if there's a crisis situation, things like that. It's by nature, a lot of it's just going to happen. We have to deal with it later. It is what it is. But like Sarah said, we know that a lot of this is going to be beyond the scope of what you can do as, whether you're on the front lines working with the individuals. You can refer them to us and we'll take it from there, because we're also watching for larger patterns. So we want to know who are the problem children. You could say, who are the insurance companies, and or maybe there's large employers in your area in Iowa, because we all know that there's some predominantly larger employers, right? Is there a pattern of an issue with their participants and qualified beneficiaries, or certain insurance company not following these parity rules? So it's good to report it anyway, so we can document that and follow those patterns. So I just wanted to throw that in there. So we're going to the second part of the presentation is going to take a little bit of a deeper dive into everything that Sarah's already talked about, and some of it's going to feel a little bit repetitive, but because it's so technical, it's probably not a bad thing to dive in a little bit deeper on some of this stuff. So basically, as a result of the Consolidated Appropriations Act of 2021, there is increased enforcement for mental health parity laws because we'll go in. I think Sarah mentioned it earlier. The original mental health parity law, I think, was released in 2008. So what this basically did with the Consolidated Appropriations Act of 2021 is it really um, it basically gave our department more capability to enforce, and gave us a little bit more specifications to follow when enforcing. So that has been, a pretty major change that's come about in the last couple of years. And so essentially what the Appropriations Act does is it requires group health plans and issuers to perform and document their parity comparative analysis with respect to design and application of NQTLs. So it's not necessarily enough for us, if we go to a plan and we say, hey, what's going on with the way your plan is handling mental health claims. We think that there may be an issue here. We're seeing these warning signs. They can't just say to us, oh yeah, everything's fine. We're doing everything in parity with mental health and surgical benefits. That's not going to be enough for our department. There's going to be some specifications, qualifications, documentation that they have to provide when requested by the department, and I'll talk a little bit more about that. But basically what it boils down to is plans and issuers must make the comparative analysis available to participants and beneficiaries on request. So not just to our department, but this is also an additional disclosure requirement of the plan, because as Sarah's been talking about, the whole first part of the presentation is the question may have already come to your mind. Well, how are we supposed to know, or how is one of our patients supposed to know if things are being offered on par? Well, they know based on the terms of their plan document. The plan document, also oftentimes referred to as a summary plan description, is the legal ruling document for the plan. It's the agreement basically between the plan sponsor and the insurance company about what is covered under the plan, what are the exclusions, what are the rights of the participant as far as appeals, adverse benefit determinations. But it also goes over in great detail about what is, at what length are certain benefits or procedures or treatments covered or not covered. And so you look carefully at that plan document to initially maybe look and see if things are being offered comparatively. But sometimes that plan document or summary plan description may not give us enough. It may require additional information to come from the employer. And so that's what we're going to talk about here. But in respect to that, you should advise your patients that they do have the right to go to their employer HR benefits and challenge the way that claims have been paid, or maybe they've been denied for one reason or another. That is their right, and it's the responsibility of the employer sponsoring the insurance plan that they get involved. They do not have the option to say, sorry, we don't have time to deal with your issue, or that's outside of our wheelhouse, you just need to talk to the insurance carrier directly. They can't pass the buck. They have to deal with it. That's their responsibility. If they're going to choose to sponsor benefits for their employees and their dependents, they have to step in when problems arise or questions. And so that's one of the big messages that we're constantly sending to our callers or inquirers, is we're saying this is your right. And a lot of them are very upset with the insurance company, and rightfully so, because let's face it, the correspondence has been coming directly from the insurance company as far as the denials, etc. However, what they oftentimes don't understand is that their first go-to should be their employer. Now, where we step in oftentimes is in a situation in which the employer is not helpful. And so we're here to take that extra step and enforce those rights. So, and continuing with this, basically what the Appropriations Act did is it specifically added new enforcement tools to ensure compliance. And it also requires group health plans and issuers to perform and document their parity comparative analysis with respect to design and application of NQTLs. Basically, I want to just reiterate that we have a lot of these laws were developed alongside other agencies, Health and Human Services and the Treasury Department, and we are issuing reports to Congress. I believe that our team, we have someone in our investigative team in our office in Kansas City, Missouri, who recently went to DC and gave a report to Congress about what we're seeing on the ground, essentially with mental health parity. So there is a communication between our department and the legislators about how this is really mental health parity is actually playing out. And some common issues we're seeing: many plans and issuers are unprepared to respond to the department's requests and had not started preparing their comparative analysis by the deadline. That's been a major problem. Many plans submitted comparative analysis that lacked sufficient detail to determine compliance, and other plans produced analysis that did not address the specific NQTL flagged in the request, or were outdated, or were prepared by a service provider to address an entirely different line of business or insurance product. So I think what's been found initially, because some of this is fairly new, I guess you could say within the last couple of years since this Appropriations Act was in 2021, is that we're basically seeing a lot of plan sponsors and fiduciaries of these health plans just really not knowing how to navigate this law and what their real responsibility is in providing requested proof or documentation that they are following it. So that's kind of something that is being navigated. And as part of our outreach and education, Sarah can attest to this, we are doing our best of our ability to communicate with various human resources groups, like SHRM is one of them. Another one, you had another one recently, Sarah, I forget what they were called. But we
HRAM.
HRAM, yeah, and these are major human resources groups that are, I think, pretty much nationwide, and they help keep people that work in the human resources and benefits world up to date on the changing laws and legislations and what the responsibility of the employers are. So we are doing our best to get the word out, so that when the department comes to the plan sponsor and says, hey, you need to furnish this or that or the other, they're doing it, and they're prepared.
I did just want to know, and you're fine where you are, is that it definitely is important to request additional information if you have questions, because it is common for some plans to not have updated things from the FDA in terms of being investigational or experimental. That's also things that we've run into. So they may have it wrong and they may need to change their whole plan document. So that's also something to keep in mind.
Absolutely. A lot of times one of the outcomes of our involvement in cases is you see plans realizing that there's an error or a shortfall in their documentation, and the way, like, because she mentioned earlier, it's not just it's what are they doing in writing and in action as well. So what's actually happening? And so sometimes we know we identify an issue or issues, and then the plan has to address those by updating their plan document and then changing how it actually plays out, and what's approved and what's not approved, etc. So we have a really helpful resource, FAQs Part 45. Literally, if you Google mental health parity, EBSA, which is, our department, and then FAQs Part 45, you'll get it. It's actually a PDF document. It's not super long, but it's going to summarize everything in this presentation essentially. And it just goes over the plans and issuers' responsibilities under the Appropriations Act and the intended enforcement behind that. And it also points out that there is a special focus on these particular NQTLs. We're looking at prior authorization requirements, concurrent review requirements, which would be, as Sarah mentioned earlier, basically making a participant continually get approved to stay on a medication or to continue treatment. So it puts a burden on them, and it can also be a barrier to their needed continued treatment as well. And then the standards for provider admission to participate in a network, including reimbursement rates. Of course, that's making it hard on a provider to participate in a network, et cetera. And then out-of-network reimbursement rates, as well as other NQTLs identified in written provisions or plan issuer practices. So I kind of touched on this earlier, but just to reiterate, plans and issuers must make available the comparative analysis with respect to each plan or coverage. And the parity comparative analysis, this would be the processes, strategies, evidentiary standards, and other factors used to apply the NQTLs to mental health and substance use disorder benefits, making sure they are comparable and no more stringently applied than those for medical surgical benefits as written and in operation. And then also specific findings and conclusions, including any results of the analysis that indicate that the plan or coverage is or is not in compliance with mental health parity. It's all about what's in writing. So we're going to expect these plans to provide their specific findings and conclusions in writing to the department upon request. So if there is an initial finding of non-compliance, the planner or issuer is expected to take corrective action and provide the department's additional comparative analysis within 45 days. Then a final determination of non-compliance would be a planner or issuer notifies all covered individuals within 7 days. That's a pretty quick turnaround time. But departments, we want our department along with Health and Human Services and the Treasury, we want to make sure that people impacted by this are notified timely when there has been noncompliance. And then departments share their findings with the state and notify Congress in a publicly available annual report. And that's a huge piece of this because that holds the insurance companies or issuers accountable when they have been found to be noncompliant with the Appropriations Act. So just a little more guidance on the Appropriations Act. And some of this, like I said, Sarah kind of talked about, but we'll just go a little bit more in depth. So when we're doing a comparative analysis, or asking, I should say, asking the planner issuer to do the comparative analysis, we are going to be looking for a clear description of a specific NQTL plan terms and policies at issue. And then an example of insufficient comparative analysis would be giving generalized statements, including more recitation of the legal standard without specific supporting evidence and detailed explanation. And then here's another example. What we would expect for comparative analysis would be to identify factors, evidentiary standards or sources or strategies or processes considered in the design or application of the NQTL and in determining which mental health or substance use disorder benefits and medical surgical benefits are subject to the NQTL. And an example of an insufficient comparative analysis that we would receive would be production of a large volume of documents without a clear explanation of their relevance to the comparative analysis. And once again, here's another one. Analysis should explain if there is any variation in the application of a guideline or standard used by the plan or issuer between mental health, substance use disorder, and medical surgical benefits. And an example of that being insufficient comparative analysis would be identification of processes, strategies, sources, and factors without clear and detailed analysis or explanation of how they were defined or applied. Now, a lot of this that we're going over may be more relevant to plans or issuers listening to this presentation. However, I think it's important for you all to know the lengths that our department, along with the Treasury and Health and Human Services, are going to enforce this. Like I said, it's not enough for a plan to just say, oh yeah, that mental health parity law, we're following that. Okay, show us how you're following it. And specifically in these NQTLs have been identified as possibly an issue, you need to show us these comparative analysis and you have to do it following these specific guidelines.
Yes, and I do want to know, Mary Lynn, I don't know if you've ever followed, if this has been a problem for you, but a lot of insurance companies are wanting to deny these NQTLs just based off pure physician notes, not even other findings or anything. It's just like, oh, that's great. You gave us this physician note, but what is it doing? Thank you. So,
Exactly.
inadequate
They're
documentation.
grasping. Exactly. They're grasping for
Mhm.
straws to deny sometimes, and it becomes really obvious sometimes because they come up with silly reasons. And what's frustrating is a lot of times they'll say they'll deny it for one reason, come to find out they've actually already been given that information. And I think that this may come up later in the slideshow, but another issue we see is they will try to oftentimes blame the provider, saying, oh, the provider used the wrong coding, that kind of thing. And really, when you dig into the issue, it actually had nothing to do with the wrong coding. And I don't know about you, Sarah, but a red flag I pick up on, and this is applicable to any denial or adverse benefit determination from a plan, is when they're denying for different reasons. So like the first time they send a denial, they're saying it's because of XYZ.
It
And
could
then
be
the
not
next
medically necessary to start off
mm-hmm,
with.
yep,
That could be
it's
the
the
first
first,
denial.
yep. And then the second time they say, we don't have adequate documentation. And it's like, well, you guys are really trying to find reasons here. And
Yeah.
it's kind of obvious. Yeah. So Sarah and I are trained to pick up on those general red flags. And that's why, like I said, we don't expect you guys, you have enough to do in your day-to-day operations and helping people and helping the public. So when these things come in, just know this is an issue we can take to EBSA. They'll look into this and help this person. And we will do everything we can to help. And so just another example, if an NQTL element of comparative analysis we often look for is discussion of the findings and conclusions as to the comparability of the processes, strategies, evidentiary standards, factors, and sources within each affected classification and their relative stringency, both as written and applied. So an insufficient response to this from a plan would be to reference factors and evidentiary standards that were defined or applied in a quantitative manner without the precise definitions, data, and information necessary to assess their development and application. So generally speaking, the plan should have or issuer should have available documentation on their processes and application to ensure it can demonstrate compliance with the law. Anything it has relied on to determine that the NQTLs applied no more stringently to mental health or substance use disorder benefits, samples of covered and denied mental health, substance use disorder, and med-surg benefit claims, so specific claims, documents related to parity compliance with respect to service providers. And once again, participants and beneficiaries can request the comparative analysis and other applicable information from their plan. And I would anticipate, and Sarah, you may echo this as well, a lot of the calls that we're getting from participants in a plan is they just want to know, like, is the plan paying right? Maybe the plan is paying correctly. However, nobody's ever told them, no one's ever given it to them in writing to prove that, right? Because it's one thing for your employer to verbally tell you, oh yeah, that claim was paid correctly, but it's another thing for them to show you how it was paid correctly. And that's what these
Right.
disclosure requirements are all about. And that's where we're taking extra steps to protect participants and beneficiaries and being able to go to the employer and say, hey, you need to provide these comparative analysis. They want to see that you're following mental health parity, because it really kind of appears as if you're not.
Right. Sometimes they'll also try to get away with something that, according to page 5 or 55 of the summary plan description, this is blah 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 blah. But that's not always enough. Sometimes it's like, yeah, it says that, but you're not looking at other information. So something else to keep in
Exactly.
mind.
They'll pull from their plan document what conveniently backs up their argument, but they'll ignore other parts of the plan document that may actually be incorrect, or may actually prove the participant's point or our point more, that it's not in parity. So that's why these comparative analysis are really central, because it's basically telling employers it's not enough to just give us random information. You have to give us specific information proving that it's in parity. So yeah, it's really good to know. And moving on to the 21st Century Cures Act, the Cures Act directed the departments to release additional guidance to ensure parity compliance and encourage the development of internal controls. So part of that is going to be the self-compliance tool that's available. The self-compliance tool is really vital. It is a tool that can be used by plans to ensure that they are complying with mental health parity, because in defense of some of these plans, I mean, mental health parity can be as mentioned early on in this lunch and learn that we're doing, is hard to understand, and it takes a little time and research. And working in it to maybe understand it. So the self-compliance tool is supposed to provide the ability for these plans to kind of check themselves. And it also makes sure that they're aware of the new disclosure, as we mentioned, disclosure work and NQTL guidance, availability of plan information, and then also the increased enforcement, plan auditing, and reporting. So who can use the self-compliance tool? It can be used by group health plan sponsors and administrators, health insurance issuers, state regulators, and other stakeholders. So what does it do? The self-compliance tool helps determine whether a group health plan or health insurance issuer complies with the mental health parity laws. And it's updated every 2 years. And, because it's the government, it's 2023 and it hasn't been updated yet. When I read this slide earlier, I was like, oh, this is kind of made me laugh. I was like, every 2 years, and we're sitting here at the end of 2023. So that tells me, fingers crossed, that hopefully, as promised, the self-compliance tool will be updated again soon. Just have to laugh sometimes. I mean, what else can you do? But what the tool specifically contains is updated examples that demonstrate how plans and issuers can correct certain parity violations. Because let's face it, once a parity violation is identified, how do they make sure that they correctly fix it could be the next hard, hurdle for the plan sponsor to get over, right? Well, we've identified a problem, but what do we do to fix it? It also has practices that may be warning signs of potential parity violations, best practices for establishing an internal mental health compliance plan. We then, of course, the 2 appendices provide additional examples, illustrations of compliance, and provide provider reimbursement rate warning signs, because I think that that's been a major, as mentioned earlier, has been identified as a big issue with the plans. Um, so this appendix does provide a chart that can serve as a framework for comparing reimbursement rates based on current procedural terminology codes. And it's not only the framework for analyzing provider reimbursement rates, but it's also, and it's not going to be determinative of compliance necessarily. It's just going to provide those warning signs of maybe these are some things that we need to look at to make sure that they are in parity.
And I
So
expect
what
more information is going to be released on that. Just a heads up. I do expect more to come.
Yeah, I think there's always going to continually be more to come, because there's always going to be challenges made to any law that's released. Whether you're looking at currently, No Surprises Act is a great example, mental health parity, these laws are more than likely going to continue to be amended and modified over time as it all plays out on the ground. So yeah, always. And that's something I'm going to touch on at the end of this presentation is, if you have not already, I suggest you subscribe to updates from our website, EBSA's website, because you'll be notified via email every time new information, technical releases are made. This could be basically telling you if maybe a law has kind of, there's new guidance on a law, for example. You may want to stay up to date with that, because who knows, we might not talk to you guys again for another 6 months to a year or longer. So to stay up to date in between is really important. So what are the best practices for establishing an internal compliance plan? We expect plans and issuers to conduct effective training and education, making sure, that they're aware of their responsibility. And this would include individuals making decisions on behalf of the plan, because you do have, people in the human resources or benefits department, maybe 1 or 2 individuals specifically, that are making those decisions about the plan, and they need to know about this. Also, ensuring retention of records and information. There are requirements under ERISA Section 107, explicitly explaining retention period, types of records, etc. And then also, as we talked about earlier, the comparative analysis that involve potential mental health parity violations or complaints. So that's a lot. It's a lot for plans to know, but it's important that they know it and stay up to date. And just to add on to this a little bit more, a big part of this is conducting internal monitoring and regular compliance reviews. So one practical way that plans can do this is by auditing samples of adverse benefit determinations. We actually ask plans to do this sometimes anyways. If we have identified there could be a problem with the way that certain claims are being paid or not paid, like Sarah mentioned earlier, the whole not medically necessary or investigative issue, that's an ongoing issue sometimes with plans. And so sometimes we'll ask them to audit their plan and make sure that there's not repeated violation, or that they're always denying a certain type of claim or request, and then they shouldn't be. We've found that they shouldn't be. So clear protocols, also in delegating management of benefits to another entity, because a lot of times you'll find that plans or issuers may point the finger at somebody else. It's their fault that they did it. Well, at the end of the day, even though we understand that employers utilize service providers to help them manage and administer their benefits, at the end of the day, it ultimately lies on the shoulders of the employer to make sure that the plan is processing and paying claims correctly and timely, including mental health and substance use disorder claims. And also responding promptly to detected offenses and developing corrective plan actions. So that goes back to when the patient, or your patient or the participant in the plan, notifies their employer of a problem, does that employer respond accordingly? Do they take action quickly? Because let's face it, there's not a lot of time to waste usually when it comes to health insurance issues, because people need the care that they need, and they need it now, not later. B, we know that on the post-service claim side, after claims have been denied, it's not going to be long before that person's going to be sent to collections. So, and that's really hard on people too, and very stressful for people. So we want to make sure that there is a prompt response from the employer to help, also including retroactive relief and notice to potentially affected participants. So if we have a plan audit their plan, and they find that, oh shoot, there were 6 other people, the same thing happened to them, we need to fix this for them. Well, not only are they going to fix it, but they're going to notify those affected participants in writing of what the issue that they've identified and what they're going to do to fix it. So I already mentioned our FAQs.
Sorry, and to us to prove that it was fixed. Sorry, I meant to say that earlier.
Yeah, thank you, Sarah. Yeah, we're not going to close out a case until every person impacted by the issue has been made whole or corrected. And Sarah and I, as benefits advisors, we are working to informally resolve issues, while our investigative team is going to be more formal in their investigation and enforcement procedures. So a lot of times, if we encounter, when I say we, Sarah and I and the rest of our benefits advisor team, if we encounter an issue that's bigger than just a one-time issue, and it's apparent that this is a huge problem, then the problem's oftentimes going to be referred to our enforcement department, and we have a huge team of investigators that would then, choose to accept and open a case or not open a case. If they open a case, they're going to not close it until every single person is made whole, and that the plan knows moving forward what to do to follow the law. So as mentioned before, we have the FAQ guidance for FAQs part 45. We also have FAQs part 39. That's a little bit older. I believe that was released in 2019. And that's also has some great information about complying with mental health parity. We also have DOL reports that are sent to Congress, as mentioned before, on mental health parity implementation and enforcement. We also have mental health parity enforcement fact sheets. You can Google that too. They're easy to find. EBSA mental health parity enforcement fact sheets. Other publications on mental health benefits. We do have hard copy publications, but also PDF digital copies of publications for compliance with mental health. Actually, I think we have them for participants to understand their rights when it comes to mental health parity. Sarah, is there also a publication on the employer or advisor side?
Not that I'm aware of yet. It's, I think,
Okay.
strictly to the employees.
Mm-hmm.
But let's try to get some questions in there if we can.
We're pretty much to the end, actually.
Yeah,
so these are the rest of the resources here, and it's not posted here, but we can share how to subscribe to updates on our website, because like I said, I think that's probably the most helpful source. So yeah, we'll leave the last few minutes here. Are there any questions?
Anyone have any questions here? You've given us a lot of information and
I know
many helpful resources. Well,
I get it.
Having worked a little bit with insurance, I've been responsible for credentialing providers before, and
Oh,
Seeing insurance companies do everything they can not to credential providers. We'd sometimes go, almost a year before we could get them on the, get them reimbursed for their service.
wow.
It was horrible. So,
Mhm.
yeah, you sort of touched on a lot of the ways insurance companies will definitely try to get out of what we pay them for.
Right.
Right, because that discourages providers who are desperately needed, right? Their services are desperately needed, and it discourages them from being in network, um, or working with,
Exactly.
with that insurance carrier moving forward if they take forever to reimburse them. And I also used to work in credentialing at the VA, and I know it's a little bit different, of course, but it is very frustrating. And so that would be something that, if you're observing that, that would be something that would be reportable to us, because then we could check in, potentially look into that issue too.
Oh, interesting. That's good. I might
Hmm.
send the slide deck or recording to colleagues, ex-colleagues of mine back in
Yeah.
Colorado. So yeah,
Hmm.
I know that's definitely one thing that they would do. Also, I'm wondering, I know many of our folks are older and are on Medicare. And the idea that a social worker is the only one reimbursable for providing care, is that ever going to change, or has that changed? I know that at this point, when you're on Medicare, I think you have to be seen by someone who is a social worker.
Oh, I
To
did
be
not know that.
truly honest with you, I don't know the answer, and I don't know if we have anything that would provide us the answer. I mean, there's research that we could do, if that would be helpful.
I wonder
Yeah.
if CMS, so Center for Medicare and Medicaid Services, I wonder if they have guidance on their website about that. So are you talking coverage under Part B Medicare? And if they're going to see a mental health person at all, it has to be a social worker?
Yeah, at least I remember
Oh.
that and same in the VA, right? And so it had to be a licensed clinical social worker as opposed to just, and every state license providers differently, but we call them
Hmm.
licensed um, psychology. Well, I think they do allow psychologists, PhDs, but not just
Hmm.
licensed providers like we call them LPCs or therapists,
Right.
essentially. Or
I think you should probably talk with Health and Human. I would submit a complaint about that with Health and Human Services, because they're more on the side with Medicare than we are. Because, like I said, these laws were developed you know, in accordance with the Treasury, because of course the taxes are involved in everything, right? So with the Treasury, but also with Health and Human Services. Health and Human Services is going to cover the Medicare side more than anything. And these parity rules, unfortunately, don't apply to retiree only plans, which could be a lot of your people too if they're older. So
Yeah.
it wouldn't, if that's a pattern you're seeing or a major issue or barrier to care, it wouldn't hurt to put in an inquiry or complaint with Health and Human Services. And I believe they have a pretty easy way to do that on their website, kind of like we do. You could probably Google HHS complaint online, and you could probably file a complaint. And one of their, kind of like how we do, they would probably just call you back and explain.
Yeah. And simply because that makes it more difficult because social workers are harder to come by, right? You just
Yeah.
can't see many of them. Yeah,
Mm-hmm.
Yeah.
that was always an issue. Yeah, it can be very difficult. And certainly when it comes to inpatient versus outpatient versus some other, and we're coming up with new ways of treating people in the community all the time. And those, whether it's clubhouse or outpatient or adult outpatient treatment court or some of these other, you know, approaches to treat people with severe mental illness, all of those things should be covered because
Yeah.
they're evidence based, and they've been proven to help people integrate back into society more fully and engage
Mm-hmm.
in fuller lives faster. So
Right. And as these more creative
Yeah.
approaches to treatment come about, and especially as mentioned before, and I think Laura's on that was on the call here, telehealth so which I understand telehealth in the mental health world can be kind of complex because like I've heard from callers, and I don't know, Sarah, if you have as well, some things can't necessarily be treated adequately via telehealth if it's mental health related, especially when it comes to treating a child maybe. But so it can become
Definitely.
complicated real quick, right? And making sure, yeah, exactly. And as I think I forgot to mention it, but just some other things to watch for too is like the eating disorders or nutritional counseling is a big hot button issue with mental health care, the telehealth, and then also ABA or autism treatment is a big one we're seeing an issue with coverages for. And I don't know if that would fall under your realm at all, but just some other specific things.
Does anyone
Yeah.
else, have any questions here? I know that, Mary and I were talking a lot about NAMI in the lobby and just ways of helping people who are new to the world of trying to find treatment for their loved ones, and how it just is so perplexing.
It can be so difficult and overwhelming for them. Yeah,
That's right.
definitely.
That's right. And
Yeah.
then they just, they might, their first, they may be, their first encounter with any of this might be in the ER with a teenager, and they don't know where to turn, and they don't know if their insurance is going to cover it. Or it's sometimes even worse with an adult child, because that adult child may not be under any coverage at all. And so they'd have to take the step of getting them covered by Medicaid. And it's just can be a nightmare for families.
Yeah.
Absolutely. The insurance world is, and it is a big barrier to care. And that's why we want to make sure that for people who we can help and who sometimes we can give them some peace of mind, sometimes, it just depends on the situation. Every situation's different, but we're here to help as much as we can on the one-on-one issues, but also the plan-wide, right? So we work on both.
Yeah.
Sarah and I primarily are working with people with one-on-one issues, and enforcement's more plan-wide. And this was actually probably geared a lot more towards the plan-wide side of things and enforcement in that. But we also help individuals with whatever issue. Like I mentioned, the guy earlier with all his substance use disorder residential treatment claims. So and Sarah, I'm sure you have open cases for mental health too.
Oh, plenty. I do also want to note that if you ever do want to get a group of people together, particularly family members who have individuals who are suffering from mental health illnesses, we have presentations directed at them too. They're not as compliance based, but they do tell them what to look out for as well, and they are helpful.
That's interesting.
And I would say one major ask we've had with that Sarah just mentioned is if you have parent connect groups. I know that there's in the mental health world a lot of parent groups that people come together who have children who may be struggling with their mental health, and what are those resources for those parents? We may be a good resource to get out to those parents. And the presentation we would give to them, as mentioned, would be different from this one. It's actually about half the amount of slides. It's not as technical, and it just basically goes over what mental health is and what their rights are with that. And maybe for them too, maybe for their child or themselves, it could be anything to support those parents. So
right. Yeah, we are happy to help in any way that we can. Mental health has been a big push for the 2024 year, and we really want to get out there and let everyone know how important it is, and that they're not alone. There are treatment options out there. There are protections. There are rights that they have.
Thank you so much. We don't want to keep you longer.
Okay. All right. Thank you for having us.
Bye, everyone.